Right, so characteristics of PCM, they are white solid crystals, they are lightly soluble in cold water, they have greater solubility in hot water. They are soluble in organic solvents such as menthol. The molecular formula of PCM is C8H9NO2. The molecular weight is 151.16. It's odorless, it has a slightly bitter taste, and the melting point is 170 degrees Celsius. So moving on to pharmacology. So this is the pathway that exists in your nervous system. So you have your cell membrane phospholipids, which are broken down by your phospholipase A2 enzymes into arachidonic acid. Arachidonic acid is then broken down by your COX enzymes to form prostaglandin G2. Prostaglandin G2 is then broken down by peroxidase enzymes to prostaglandin H2, will then be subsequently metabolized by your other enzymes to form your PGA2, PGI2, TXA2. So where does paracetamol act? There are many theories, but it's commonly understood that your PCM acts on your COX enzymes as well as your peroxidase enzymes. So it inhibits the pathway here as well as here. So it inhibits the formation of your prostaglandins. Alright, so pharmacokinetics of APAP. APAP is metabolized in the liver by glucuronidation and sulfation at therapeutic doses. A small percentage of 4% is converted by your cytochrome P450 enzyme into a reactive toxic intermediate called the NAPKI or your N-acetyl-T-benzoquinolamine. The NAPKI becomes non-toxic when it binds to glutathione. Alright, so this is what I was talking about earlier. So at therapeutic doses, if you take PCM at a therapeutic level, acetaminophen gets conjugated to form glucuronide, it gets conjugated to form sulfate, and a small amount of PCM will undergo oxygenation by your cytochrome P450 enzyme to form your NAPKI. So NAPKI at therapeutic doses is okay, although it's toxic because it will be conjugated with glutathione. If it's conjugated by glutathione, it will then form cysteine and mercapturic acid conjugate, which is non-toxic, which will then be excreted in the kidneys. All right, so what happens in overdose? How do you get PCM overdose? You get PCM overdose when there is increase in your NAPKI. And how does this happen? This happens because you have CYP enzyme induction. So you have certain medications that induce your CYP 450 enzymes, for example, your phenobarbitons, your phenytoins. You also have glutathione depletion as well as inhibition of your glucuronidation. So if it's inhibited here, the pathway will be more concentrated here. So we have more NAPKI. When you have glutathione depletion, NAPKI cannot bind to glutathione, therefore your NAPKI levels will be elevated. So when your NAPKI is unable to bind with your glutathione, what happens is it will react with your cysteine group of hepatocellular proteins and will cause hepatocellular injury. So precipitation of acetaminophen poisoning. An acute single injection of acetaminophen greater than 10 grams or 150 or 200 milligrams per kg, depends on the guideline that you use, in adults or children is considered hepatotoxic. So the scenarios, patients may come with acute injection, whereby they present to you less than 8 hours post-injection. They can come to you with massive injection, in which they ingest more than 30 grams or more than 500 milligrams per kg. They can come with chronic injection within 24-hour period or 48-hour period. They can take in sustained release PCM, staggered doses of PCM, or they can also take in repeated supratherapeutic injection. All right, so when they come to you, what should you ask the patient? You should ask the patient the dose of the PCM that they ingested, the timing of injection, the formulation, whether it's immediate release or extended release, any history of liver diseases, any other medications that the patient is taking, chronic acetaminophen injection, chronic alcohol use, or or any co-injections with other medications. So this, as you all know, PCM toxicity leads to liver failure. So these are the 4 stages of liver failure. So you can classify them into stage 1, 2, 3, and 4. So the first stage happens within the first 24 hours. It's called the initial stage. So patients can either be asymptomatic or they can present to you with specific symptoms such as anorexia, nausea, vomiting, or diaphoresis. The second stage takes place at the 2nd to the 3rd day. It's called the latent phase. So during this stage, patients can have right upper quadrant abdominal pain. They can have elevated transaminases. The 3rd stage is called the hepatic stage. This takes place during the 3rd to the 5th day. So patients can have systemic symptoms when you take their blood. They can have peak AST, ALTs. They can have features of hepatic failure and encephalopathy, acute renal failure, or pancreatitis. So the last stage is stage 4, where patients can either recover, patients can have multi-organ failure, and eventually die. All right, so among the complication of liver failure is hepatic encephalopathy. So there is this criteria for hepatic encephalopathy called the West Haven criteria. So grade 1 to grade 4. In grade 1, patients have inverted sleep pattern, they can have forgetfulness, malconfusion, agitated, irritable, they can have tremors and apraxia. In grade 2, they start to become more lethargic, have slow responses, disorientation for time or place, subtle personality changes. In grade 3, they become more somnolent, they become disorientated to place, they have hyperactive reflexes, they have obesity signs, and grade 4, they become comatose. All right, so how do we manage PCM poisoning? So the approach of management applies to all emergency cases. You start off with airway breathing ventilation. So if the patient comes to you with an obstructing PCM and the patient is unable to maintain the airway, you can consider intubation. The patient's SpO2 is not sufficient and the patient's breathing effort is poor, you can give the patient oxygen supplementation. If the patient is hemodynamically unstable, you can consider giving the patient rates. So you should monitor the patient's vital signs and establish an IVSS. All right, so ultimately you need to manage the patient using medications. So if the patient presents to you within the first hour of injection, you can give the patient activated charcoal. So how do you give it? You can either give it orally or through a feeding tube. You give 50 grams in 200 mils of water. For pediatrics, the maximum dose is 1 gram per kg. Another medication that we would like to administer is NAC. It is given when the PCM level is in the toxic range or the history of presentation is suggestive of significant overdose. We'll explain more about NAC later. Right, so when do you sample your TDM levels? So it depends on the time of the presentation. If the patient presents to you within 1 to 8 hours after injection, you sample the TDM level at least 4 hours after injection. If the patient presents to you after 8 hours after injection, you sample immediately on admission. If you are unsure of when the patient took the PCM, you sample immediately on admission. If the patient has repeated supratherapeutic injection or chronic injection, you also take the TDM levels immediately on admission. So other bloods that you should take are your LFTs, your coagulation profile, your DXT levels, your RP, blood gases, as well as ECG. So this is the Rumet-Matthew nomogram. So the x-axis presents the hours of injection, the y-axis presents the PCM levels. So you have 2 lines. You have your A line and your B line. Your A line is your non-high risk treatment line, and your B line is your high risk treatment line. So there are certain patients who you would use the B line to see whether or not you need to administer NAC. So these are some of the criteria that you would use in order for you to use the B9. So in patients who have decreased hepatic glutathione stores or patients who are taking medications that would induce your cytochrome P450 microenzymes. Alright, so limitations of the nomogram, this one, you can only use it if the patient has a single acute PCM injections of immediate release. It does not apply to co-injections or modified release PCM. It is not validated 4 hours or after 16 hours. Your nomogram confounders, incorrect history of timing, multiple injections or chronic use, factors that increase risk of toxicity such as chronic alcoholism, malnutrition, drugs that increase your acetaminophen toxicity, injection more than 24 hours or wrong units. So this nomogram you can only use if the patient ingests after 4 hours. Alright, so that is in patients in which patients yang you tak boleh nak pakai this nomogram are patients who have chronic ingestion. So patients who ingest excessive paracetamol for a therapeutic purpose or ingest therapeutic doses of PCM and have symptoms of acute liver injury are managed as repeated supratherapeutic ingestion or RSTI. Acetaminophen level cannot be plotted on the rheumatoid nomogram that is used in the setting of acute injections. So patients who are at risk of RSTI, there are 3 types of patients. The first one is if the patient takes in at least 10 grams or at least 200 milligrams per kg, whichever is less over a single 24-hour period, or if the patient ingests more than 12 grams or 300 milligrams per kg, whichever is less over a single 48-hour period, or if the patient takes in more than a daily therapeutic dose, which is more than 4 grams per day for more than 48 hours in those who have abdominal pain or nausea or vomiting. If one of the criteria is met, then you take the AST and the ALT level as well as you send a DDM sample. When the results come out, if the PCM level is more than 20 milligrams per liter, or you have AST or ALT that's more than 50, you can start NAC. After that, you repeat back the bloods 8 hours after that. If there is significant lung injury, you expect your transaminases will be elevated. And then if you repeat the bloods 8 hours after that, and if your PCM level is more than 10, you should complete the NAC for 20 hours. So for those who have ALT or AST more than 1000, you should give the NAC for 20 hours as well. So if you give the patient NAC for 20 hours, 2 hours prior to the completion of NAC, you should check back the DDM levels and then as well as the ALT and AST levels to determine whether there is need for ongoing NAC. Alright, so this is basically a summary of what I told this now. Alright, so now we move on to N-acetylcysteine. What it is like, actually it's a specific antidote. It is metabolized into cysteine, which is a glutathione precursor. It increases the supply of glutathione. It must be initiated 8 to 10 hours after injection. The benefit is questionable if it is administered after 24 hours of injection. So you have 2 routes of administration. You can give it orally and you can give it via intravenous route. So if you give it via intravenous route, your loading dose is 150 milligrams per kg in 200 ml of D5 over 15 minutes, followed by 50 milligrams per kg in 500 ml of D5 over 4 hours. And then at a slower rate, you give 100 milligrams per kg in 1 liter of D5 over 16 hours. Alright, so what can you give in ED? You can give Maxolon, ranitidine, you can start NAC. If you want to give charcoal, you can give it via stew, or if the patient can take in orally, you can give it via orally. You can consider hydration and monitor vital signs. So the sequelae of your liver failure, you can consider referral to a liver transplant center based on the modified King's College criteria. You can also consider hemodialysis in case of massive ingestion. So when do you consider dialysis? If the AP level is more than 1 gram per liter and NEC is not administered. If the patient presents with altered mental status, metabolic acidosis, elevated lactate, and the PCM level is more than 700 milligrams per liter, and NEC is not administered, and if the patient presents with an altered mental status, metabolic acidosis, elevated lactate, and an AP level is more than 900 milligrams per liter, even if NEC is administered. All right, so this is the King's College criteria for acetaminophen toxicity. This is used if you want to refer the patient to a center for liver transplant. So if the pH, arterial pH is less than 7.3, if the INR is more than 6.5, or the PT is more than 100, if the creatinine is more than 300 micromoles per liter, if the patients have grade 3 or grade 4 hepatic encephalopathy, if the lactate is more than 3.5 after fluid resuscitation, or the phosphate is more than 3.75 at 48 to 96 hours. Right, so the take-home message, the hepatotoxic dose is more than 200 milligrams per kg or more than 10 grams, whichever is less within 24 hours. The first stage of PCM toxicity is largely silent. Be aware of the limitations of the rheumatic nomogram. The management depends on the timing, and when in doubt, you just can administer NEC. That's all. Thank you.
Okay, Assalamualaikum and a very good morning to everyone. For the top-up CME, it's a short one. I'll be talking about specifically regarding NEC, which is our antidote for PCM poisoning. Regarding the different regimens that's available, what we're using, or traditionally we're using the 3-bag method versus 2-bag versus 1-bag. This is actually a topic that we tuned in during the recent AMAS conference. It was actually presented by Professor Stephen. He's a clinical toxicologist as well as a professor and medical director at the New Mexico School of Medicine. He also largely studies or do a lot of scholarly works specifically on PCM. So a bit of a background. All right, so a bit of a background, as mentioned by Dina earlier, NEC is the standard management for PCM overdose or any PCM-associated hepatic injury, which includes the administration of either oral or IV, but more commonly IV because oral NEC is treated with nausea and vomiting. So there's a lot of different treatment regimens. But the treatment regimens for optimal efficacy and minimization of adverse reactions and medical error are unclear. So using the traditional 3-bag method, there's a lot of reports of allergic reactions, compounding errors, infusion rate errors, and interruptions in between the bags, which have been documented. So the 2-bag and 1-bag administration methods have been explored as a means of reducing these events. So this is the regimen of the NEC 3-bag method. It dates even back to 4 decades. As you can see here, that the total dose is 300 mg per kg, and you can alter it if the PCM levels come back at a higher dose. So you need 3 bags at 3 different dilutions and 3 different rates. So if you can, if I can bring your attention that the loading dose is high and it is rapid, it runs over 1 hour. As for the efficacy, it is actually virtually 100% effective if you administer it within 8 hours. For severe hepatotoxicity, you can see that it's actually 0% when started within 8 hours. So it's a very time-sensitive or time-limited treatment. The incidences of severe hepatotoxicity increased to 7% when started within 10 hours, and increment manner, 43% within 10 to 12 hours, 56% within 12 to 15 hours, and 82% within 15 to 24 hours. As for the safety, which is described in terms of adverse drug reactions, anaphylactic reactions is reported in 0.2 to 21% of cases with a mean of 14%. Now that is a very wide range between 0.2 to 21%. So the wide range is mostly dependent on how well we recognize anaphylactic reactions and as well as how well we report these cases. As for errors in the administration of three-bag method, actually there's a lot of cases, there's a lot of reports of errors that not reported in a systematic manner. However, a study of errors of administration of NEC of PCM overdose in patients in Malaysia, this was published in the Hong Kong Journal of Emergency Medicine. It is actually a clinical audit study which is performed retrospectively between 2008 to between 2008 to 2011. So patients received NEC, and the study population is ranging from 13 to 87 years old, and the overall prevalence of intravenous NEC-related medication errors was found to be 84.3%. So that's a really significant or really high number of medication-related errors. So of those errors, 5.9% is of the wrong dose, 37.3% is of the incorrect infusion rate, 8.5% experienced interruption between the treatment, between the 3 bags, and 66.5% is due to unnecessary administration. So this shows that there's a very high prevalence of medication errors in terms of administration of intravenous NEC. So further studies needs to be done so that we can prevent from unnecessarily burdening the treatment cost and unnecessarily administering NEC, as well as prevent unnecessary hospital admissions. So this now was the 3-bag method, which is traditionally used everywhere in the world, including Malaysia. But more recently, some countries have employed the 2-bag method, specifically Australia and New Zealand. So the difference is that, as the name suggests, it is 2 bags instead of 3 bags. The total dose is the same, which is 300 mg per kg. However, if I can draw your attention again here, the loading dose is over 4 hours instead of over 1 hour as compared to the 3-bag method. So, and you have the specific loading dose as well as the maintenance dose. So as for the efficacy, apparently there's no apparent difference between the efficaciousness of the 3-bag method versus the 2-bag method. As for the safety, there's a remarkable or significant reduction in acute allergic reactions versus the 3-bag method, being that in the 2-bag method, it's reported that acute allergic reactions occur in approximately 1 to 5%, versus in the 3-bag method, it's 7 to 17%. This is because of the slower rate of the loading dose, so it reduces the chance for patients to get anaphylactic reactions. As for the error, because you are dealing with 2 bags, the necessity to change 2 bags instead of 3 bags, so there's less opportunity for errors in the 2-bag method, being that in it's reported approximately in the 2-bag method, 5% of errors occurs, versus in the 3-bag method, 12% of errors occur. As for the 1-bag method, as the name suggests, again, it's only using 1 bag. However, there's a rate change after 1 hour. So the total dose is actually higher, the cumulative dose is actually higher compared to the 3-bag and 2-bag method, which is the 3-bag and 2-bag method is 300 mg per kg. However, in the one bag method, it's 400 mg per kg. It uses a single bag with a single dilution, which is, if you notice it, it's actually much lower, which is 30 gram of NAC in 1 liter or 5% dextrose. And you run it over a bolus of 150 mg per kg over 1 hour. Then after the 1 hour, you just change the rate to 12.5 to 14 mg per kg. The potential benefits is that it's simpler because you use just one bag, and it reduces the interaction or the time gap between the delivery of the second bag in the 2-bag and 3-bag method. It also decreases nursing work, and if there's programmable pumps, you can use the programmable pump to just set to when the rate change occurs. However, the potential risk is that there's still a risk of guiding error if you wrongly calculate the dose from the very beginning, so it will be compounding to the second rate. And sometimes you can still see gaps in the IV rate change or if there's any errors in the pump programming. So for the efficacy, there's no apparent difference. However, the 1-bag method is studied less extensively as comparative to the 3-bag method and the 2-bag method. As for the acute allergic reaction rate, it's reported to have allergic reaction between 4 to 14%, which is still significantly lower as compared to the 3-bag method. As for the error, the dose interruption rate of more than 60 minutes occurs in 4% of cases, versus in the 3-bag method, which occurs 2/4 of that, which is 8%. The overall dose error rate is 13% in the 1-bag method versus 50% in the 3-bag method. So in conclusion, the 2-bag and 1-bag NAC appear to be as effective as the 3-bag method, and one may even consider or opt for the 2-bag and 1-bag method because the allergic reactions are reported to be seemingly reduced as compared to the 3-bag method. However, we do need further additional studies because all the previous studies that's mentioned is actually retrospective studies. So there's not enough randomized prospective studies that's done for comparing between the 3-bag, 2-bag, and 1-bag method. So these are the references. Yeah. Okay, thank you. Any questions? Which method is used in ED Sungai Buloh? We are using the 3-bag method.
Any questions? Any announcement?
Just some input on the PCM poisoning. In hospital camp, previously when I was there, usually when they come to you after 12 hours of injection, the TDM level may not be accurate. So at that time, your clinical judgment is more beneficial than relying on TDM alone. Let's say they have abdominal pain, vomiting, then they have derangement of liver function. Usually that thing will ask to start the NAC. Besides that, sometimes our liver, upper TDM level will be very slow in clamp. So that thing will start the NAC just by looking at the abnormalities in our liver function, deranged INR, itu pun kita dah start dah, tak payah tunggu TDM sebenarnya. Okay, and another thing is that the NAC usually you load for 20 hours, right? So before the last 2 hours, you must take the LFT ready. Don't wait until the last 20 hour baru nak ambil. Because like looking at our lab efficiency, so by the time they reach the 20 hour, we must have the liver function so that we can decide to start the second cycle or not. Okay. And then just bear in mind the extended release PCM too, we cannot rely on the nomogram. Yeah, so that one also clinical. That's all. Any input from Pakar?
In the beginning of the slide, Dr Dina mentioned that PCM poisoning is the most common overdose in Malaysia. And if patient comes with PCM injection, we also need to think of other co-injection. And it actually works vice versa. So if patient comes with injection of other drugs, so you need to think about PCM as well, because PCM is the most common. Usually, they will ingest PCM first before taking the a bit of the unusual drugs. So basically, if they come with other injection, it's better to send the TDM or PCM, even though we don't have the history, because this kind of patients, they don't tell you 100% about the history. They have some mental issues, stress, or even suicidal, so they won't give the accurate history that you would like to have. Just one for me to.
Assalamualaikum. Secara tampak ya untuk isi satu slide. So we bandingkan antara one back to back time method. So the one that we doing right now adalah three time method, betul? Right? So based on the studies that have been conducted on this one, we see one time method is actually good. It reduces the electrolyte reaction. And it reduces the workload on our staff. The main problem is sebab dia dalam satu bag, so kita kena settlekan itu usually sometimes nurses terlupa, dia overlook dan dia terlupa nak reducekan the flow. Right? Di soalan dengan clamp, menurut data rajini, the clinical toxicologist, dia kata dia orang tengah menggunakan two-bag method. So bila saya tanya kenapa maksudnya dia tak consider menggunakan one-bag method, dia kata dia nak, tapi because of the workload ada staff yang akan membebankan dia orang, sebab tu dia cuma buat dua saja. But in terms of efficacy, I think it's same, sama saja, cuma the risk of anaphylactic reaction saja yang berkurang.
Any other questions?
Jawapannya dia tak perlu, tapi dia punya biasanya pharmacist akan take charge, dia akan inform. This is to remind our efforts and also our staff. Itu big question. So dia punya when we send PDM, they will usually follow up. Here the pharmacy quite efficient in that sense lah. And we send PDM, they immediately call back. So once we send PDM for PCM and any time, so they will call us back immediately. So usually they will take charge of that side of it, to inform or to monitor any such incidents lah. Kalau suicide attempt, itu nanti berbincang lain lah. Tapi untuk PCM poisoning ni tak perlu inform apa-apa, maksudnya tak ada form notification lah.
Polis report pun tak perlu buatkan.
Polis report saya rasa dah tak perlu lah untuk suicide attempt lah, sebab kita nanti criminalize itu tergantung kes tutup saya. Kapan? Apa yang aku barang tak tahu. Saya belum.
Kalau patient indicated for macam liver transplant, do we refer or do we refer maybe to
lah. Percakapan belum bukan dulu. Nak biasa kita ikut lah.
I mean, if pregnant patient with PCM toxicity can start NAC. Besides visual, just to test skill. If you got a patient next time that come in, taken paracetamol more than 150 mg per day, at 6 hours, do you start NSC or you wait? Just to make sure the basic concept you get. 6 hours, but I should start NSC ke tidak? Start NSC terus ke? Alright, at 6 hours, yeah, right, you go and take the TDM level. If the TDM can just available within 8 hours, so you wait, you start straight. If you got another scenario, come at 12 hours of the injection and it's a toxic dose. Do you take TDM level and wait, or you start? Who start? You start because hesitate more than 8 hours already. So just remember the 8 hours rules before and after.
Ada soalan lagi? Kalau tiada soalan, saya mau menang sebenarnya. Oh, dispute ada isi atau tidak? Setiap dispute saya, macam saya kerja dulu. Kalau di Sabah pun, kadang kedalaman pun ada juga. Doktor PCM level kalau misalnya level yang di 150 mg/kg dan history suggestive, kita start terus lah. Tapi bear in mind that starting NEC after 8 hours, the efficacy is not as good as starting less than 8 hours, because the risk of developing hepatotoxicity after 8 hours is 100%.
Dekat fisik ada NAC, droplet dia tak ada. Negatif pula
Betul.
Next time, any of you terhantar ke district or what, if the drugs are not available, you can discuss with your MYC if no pakar. If they say a district of pakar, you need the drug, you see a lot of cases, you can suggest because they have maintained in the pharmacy. You can make the stock flow available. So drugs that are not used yearly, then the pharmacy will not purchase. Drugs which are needed when you suggest you have cases, then they will make it available. In young is also, it's a temporary solution. And be proactive and go.
Satu announcement daripada Dr. Afifah dan juga Dr. Suji ini berkenaan dengan patient flow masing kena hybrid nanti lah. So kita akan menggunakan flow ini sebagai persiapan untuk kita bertukar menjadi hybrid nanti. Okay, yang pertama adalah kita akan minta semua EPO untuk practice di mana semua case new case di zone lepas dia dapat RTK diminta menghantar pesakit terus ke observation sebab observation saja yang buka So kita punya contingency plan adalah untuk buka asma B dan juga fever center lama. So asma B adalah untuk pesakit-pesakit COVID positif, bila kita buat PK dia zone positif dan terus masuk observation ataupun di asma B. Sekiranya kalau observation penuh. Okey. Kemudian sekiranya kalau pesakit itu didapati negatif dan tidak mempunyai respiratory symptoms, pesakit akan dihantar ke fever center yang lama. Dan sekiranya kalau observation ward penuh. So macam mana mekanisme untuk mengaktifkan asma B dan juga fever center yang lama adalah melalui pakar ataupun penyedia on the floor. So kalau bila kita tengok yang zone yang boleh penuh, observation ward tu yang boleh penuh, terus dia inform pakar yang in charge zone itu ataupun penyedia. So dia akan buka terus asma B dan juga fever center lama dan dia akan distribute paramedik ke sana. Okay, itu nombor satu. Nombor dua adalah nombor dua adalah sama tu. So kalau patient dalam ONID ataupun hydrolis kandimal diberikan zoom ataupun diperisas selepas 1 jam atau 2 jam dan kita tengok patient stabil atau memerlukan active intervention terus hantar ke ACO. Untuk patient sehari ataupun POI ataupun kes-kes yang tunggu PCR daripada yang itu hantar terus observation. Sama saja di sini kalau ada penuh observation tinggi asma B dan juga fever center lama. Kalau untuk yang COVID category 3 ataupun 4 memang dalam asma kerja dia naik terus masuk ke dalam ward kan. Tapi sekiranya kalau new case sampai pukul 12 tengah hari, patient yang pukul 7 pagi yang belum dapat katil, pindah saja awal ke observation ward. So kita nak praktis, basically kita nak buat dan kita ajarkan yellow zone sebagai transit point. So maksudnya bila dia masuk dalam yellow zone, dia akan buat RTK, kita buat simple clucking, dalam masa 15 minit, kita dah tahu dah sama dia adalah respir atau non-respir dan kita tahu ini adalah COVID atau tidak. Selepas itu, terus hantar ke zon-zon yang sepatutnya. Contohnya kalau dia positif dan ada respiratory symptoms, belum masuk observation, kalau observation penuh, masuk ke asma B. Kalau misalnya tiada respiratory symptoms, RTK negatif, hantar ke fever center lama. Jelas ya? Sehingga kita gunakan dia khusus pakai transit point saja, bukan tempat kita nak manage. Sebab kalau di hospital lain, mereka buka khemah kat luar dan dia buat RTK di luar. Patient kaki patah ke apa ke, wheelchair ke, buat RTK kat luar tu, baru masuk. So kita nak bantu kita masuk, kita certify, positif negatif, dan baru kita tolak. Yang membezakan kita dengan hospital lain. Ada soalan? Respiratory symptoms, RTK negatif, observation 1. Kalau misalnya observation penuh,
dia akan stay dekat yellow zone juga.
Ya betul, dia akan stay di yellow zone.
Jadi dia trial dulu untuk kita hybrid. So kalau kita implement awal, nanti bila hybrid kita tak cukup. So transit tu memang yellow zone ni tak perlu tak kata kerja tak banyak sangat. Cuma maksudnya transit lah. So kita kena tolong orang dekat observation. Kita kena tambah dekat observation lah. Tapi kalau observation penuh ni, sekarang ni saya tahu satu isu apa tu datang naik bila kita buat benda ni. Gaduh antara puan ada di kepala. Gaduh antara betul. Ya, ini adalah arahan ketua jabatan. Okey, so kalau dia orang nak gaduh, dia ada orang gaduh. Biasa standard jawapan ialah baru masuk resolusi tak boleh naik kata. Itu bukan masalah korang. Okey, kita datang transit buat kerja, dah kita table hantar pergi observation. Okey, kalau observation penuh, dia akan datang komplain kat kau. Time tu kita jumpa pakar atau penyelia untuk activate. Lagi tak penuh observation, jangan dengar cakap-cakap. Sebab memang akan gaduh dengan staff ni, memang akan gaduh, and we are the one who will get trapped in the middle. Especially when we favor certain activity, we favor certain staff nurse ke, benda memang akan ada. So kita kena start benda transit ni awal, sebab nanti dah nak pergi hybrid. Nanti bila hybrid, patient lagi ramai dan akan slow the system. Okay? So memang kita nak implement ni as soon as today, possible trial and error. Okay? Nanti kita akan type message ni dalam group supaya semua orang boleh tahu apa yang tak dengar melalui CME.
Kalau misalnya kalau COVID positif, kita boleh start dalam batch, itu tak masalah. Tapi bila PY center saja problem, PY center, kalau PY patients, ya, itu yang problem sikit kita tak dapat. Kalau misalnya keluar even RTK negatif, kita boleh start itu double.
RTK negatif boleh tengok.
Boleh tengok.
Link to strong and try to
sebab we have because now the patient load is reduced here. So X-ray have their own thing to do in their scanning area, the CT, blah blah blah, everything they want to lie on the wall. So ini persefahaman. Last time when patients were a lot, we cannot send, they came to us. Now patient is reduced, we have to send. Have to talk to our staff of command.
Actually, as doctors and OEP, in charge of the zone, although they run the team leader, so to ask them to send, actually you have the right, you can move, you want to send, you ask them to send. You know, remember before COVID kan, kita ramai patient kan, send dia kan, tak ada masalah, tak ada, send, sama ni. Any reason sebab dia orang sedang X-ray COVID patient ke?
Usually they don't give any reason lah.
Actually can your lower ranking.
Sekarang orang dah start to set the use of pesawat. Dan masukkan itu mereka apa nama pesawat macam mana dia. So kita bisa tahu dari segi DJ in space data lain-lain. But that's a pesawat. There's no evidence of COVID punya. Okay.
Any other questions or issue about law? Thank you. For group D, That's good in energy.